Good afternoon, everyone. My name is Daphne Stereotis, and I'm an associate with CAQH Core. It's my pleasure to welcome you all to our first town hall of the year. We have a lot to cover during this session. We'll kick things off with an overview of CAQH Core and federal and industry activities. Then we'll look ahead into our 2021 roadmap and goals for the year. Our staff work group leaders will cover our new value-based payment and connectivity operating roles, and as well as the attachments and claims operating roles that are currently under development. We will then cover our certification and measurement program. Finally, we'll conclude today's session with a questions and answers period. Before I hand the call over, I'd like to mention a few logistical items. A copy of the slides and the webinar recording will be emailed to you all tomorrow afternoon. I also want to encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. So with that, we can get started. I'd like to introduce our first speaker, CAQH Core Director, Bob Boatman. Bob?
Great, thank you, Daphne. And I want to also reiterate Daphne's welcome to you and Happy New Year. Welcome to 2021. If we move on to the next slide, you'll see that, as always, CAQH Core is a mission and vision-driven organization. We are industry-led, both by our core board as well as our participants. They make up quite a bit of the entire industry with healthcare providers, plans, vendors, government entities, standard-setting organizations, and any of their associated associations. So we really work within the industry for the industry. And our role then is to really develop business operating rules to help the industry make things more effective, automate the connection between providers and plans, and really build a network so that interactions that do take place are cheap, efficient, and really engender a better healthcare system. We have been designated by the HHS, the Department of Health and Human Services, as the author for national operating rules related to HIPAA-covered administrative transactions. So part of our work is always going to be based in what we can do for the HIPAA-covered transactions, but it's not always our scope, right? We are always trying to look for ways that we can interact with providers and plans and make any sort of interaction between those two entities easier. Moving on to the next slide, we have done this for a number of years now, 15 years. We've been working and developing different rule sets to address the HIPAA transactions. So you see those different types of interactions that a provider and a plan may have, like an eligibility and benefit verification, or a claim status, or a prior authorization, even benefit enrollment and premium payments. We have different sets of rules for each of these, and we have different types of rules. We have an infrastructure rule that defines very specific types of interactions that need to take place around response times or system availability. Acknowledgements, when this transaction is sent and received by a health plan, it has to be acknowledged so the provider's not thinking it went into a black hole somewhere. We also have very specific connectivity rules, and the rules are kind of evolving through time with connectivity. As you can imagine, technology changes, security requirements change, authentication requirements change through time. So this is kind of an ever-evolving type of rule set, and it applies to different types of transactions. We have more update on this in a little bit on our latest version of our rule, of our connectivity rule. We also have data content requirements, very specifically for eligibility, the 835, the ERA transaction, as well as the 278. And we'll have an update too from legal a little bit later on the 834 data content rule that was just published. We do have some other types of rules. As I mentioned, we do also tackle other types of interactions that need to take place between providers and plans. So we've added other types of rules to ensure that we foster that type of ease of business use. So we see that with our single patient attribution rule, our EFT area enrollment data rule, as well as our prior authorization web portal rule. Again, we're always looking for other ways to facilitate and foster an interaction that is cheap and easier to do and more efficient, and really brings the data needs from the provider to the plan. Moving on to the next slide, we do want to provide a quick update on the federal actions that have been taking place, some really recently. Of the first one there, you see that CMS prior authorization final rule was published in mid-December with a notice of proposed rulemaking. Core staff, along with the core board, worked diligently to write a comment letter that we submitted to CMS prior to the deadline, which was January 4th of 2021. So very quick turnaround time between the proposed rule, the comment period, and now earlier this week, the final rule was published on Monday. So even as we were developing the slides, things have changed quite quickly. Even with some of the, and I know we'll probably have this type of question a little bit later on in our Q&A section, with the Biden administration coming in, what does this mean for this rule? We'll have to wait and see, but there's already been some discussion of putting anything that was published in the last 30 days of the Trump administration on hold indefinitely. So more to come on this, but we do have our comment letter available for you. Next, we do have two updates related to the federal advisory committees. The Health IT Advisory Committee that makes recommendations to ONC meets on February 10th, and the National Committee on Vital and Health Statistics, that is advisory body to HHS, will be meeting in March 31st or April 1st. We'll be attending those meetings as we can, and we'll be providing updates in our next town hall. But again, we just want to make you aware that these meetings, again, all happening in this first quarter of 2021, are going to be important for us as an industry, and we're monitoring this for you. We do want to do another deep dive a little bit on the recent work from NCVHS over the last couple of quarters. If we move to the next slide, you'll see that the work that we've done, and some of this might be a little repetitive because we did talk to you about in February of 2020, already a year ago, our board sent a letter to NCVHS proposing that the core prior authorization and connectivity rules should be mandated under HIPAA. In August of last year, NCVHS held a hearing to review and hear feedback on those proposed rules. Our very own April Todd, our SVP, Tim Kaya, who is the COO of United, and Sue Turney, the CEO of Marshfield Clinic, all chairs of our board here at CAQH4, attended and presented on behalf of CAQH4. The agenda included lots of presentations from a number of organizations, both CMS National Standards Group in particular, X12, number of health plans and associations. Providers, as you can imagine, were very interested in this topic. Many vendors and associations that related to vendors also presented. We do have a link here for all the comment letters that were received. You can look and validate the information that perhaps an organization that you're a member of, or would you want to see what other members said. Those are all available for the public to consume. But you can imagine many of the letters that came in directly keyed off with the hearing and testimony from the folks that attended the meeting and presented on. So it was really helpful to see both the written comments as well as hearing the same comments debated and discussed during the hearing. Later in November, NCVHS finalized their recommendations and published a recommendation letter on November 23rd, so a little more recently. And on the next slide, you'll see that they actually had a very specific number of recommendations, and what they are were, the first was to include a standard, an attachment standard. As you can imagine, prior authorization is very tricky without attachments, because so much of the information that a health plan needs to validate the request for the prior authorization is based in the clinical information. It's based in the in the clinical record that the provider maintains. And without a national standard for attachments, it's been a challenge to automate the prior authorization transaction. NCVHS also supported and encouraged the voluntary use of the two proposed operating rules for PA. They did recommend to HHS a 12-month voluntary use phase that can be used to help monitor the industry as they continue to evolve their adoption of both the 278 transaction, the various standards that are out there and available for attachments, and the automation components that health plans, providers, and their supporting vendors and clearinghouses are making over the course of the last couple of years. But in particular this year, what can we do as an industry to move the needle forward? They did recognize the strong support for and the value of the proposed rules, but also acknowledging that HHS and other industry initiatives are in the midst of the process. And one of those we saw actually, again, in December and January was the proposed rule. They did encourage, they did not adopt the proposed operating rule for connectivity, but did encourage us to finalize a new version of the core connectivity rule. We'll hear in a few minutes from Emily that we have actually completed that work, and it is now available for industry implementation and adoption. Another recommendation from NCVHS was to increase the visibility of enforcement information related to the operating rules. And again, this is to ensure that as HHS is evaluating the industry's adoption of the standards and the operating rules, to make that information more available to the larger public and larger industry actually, so that the industry can understand where there are pitfalls, what are some of the challenges for implementing the standards and their associated operating rules. What can we do as an industry to continue the discussion and work on those challenges? So again, great recommendations, a way to move forward with the operating rules as well as the industry adopting the standards necessary for a more efficient prior authorization process. We go to the next slide. We'll move into the next section of our presentation today, and that is our 2021 roadmap. Now, we at CORE and our participants, and including our board, are really important in ensuring that any type of project that we may take on or want to or wish to proceed with really has to align with our mission, vision, and our industry role. We have to address very specific market needs. We have to make sure that things are more efficient, more predictable, and more uniform with any kind of project that we might do, including developing operating rules that continue to align administrative and clinical activities, obviously with prior authorization as a prime example, but also, right, let's not forget that attachments play a key component for many types of claims and adjudication of claims. There's lots of attachments related to the member and related to the provider in audits that take place. So those types of clinical administrative data sets and data needs are going to continue to evolve. And we at CAQH CORE, as well as much of the industry, are continuing to evaluate where the industry is at, where it should go, and how and what steps it should take to get there. All related to that are the different types of standards and the need for interoperability across systems, applications, vendors, health plans, and providers, right? All the different constituencies within the industry have to be able to adopt and develop standards in a timely way, and then also be able to ensure interoperability across that entire spectrum. So we at CORE, again, help to align those standards and technologies, ensure expectations for data exchange, and close the automation gaps as we continue to evaluate the changing business needs. These are all going to be key components for us as we address 2021 and as we develop our 2021 goals. On the next slide, you'll see exactly what some of those goals are. We have a handful of them. They're key for us because we have worked with our CORE board and our CORE participants in identifying where we need to move forward next. And we're going to continue to work on value-based payment and build upon our existing rules and enhance the work that we've done there. Again, we'll have a little more of the detail a little bit later on in the presentation for some of these, but as a way of kicking them off, we want to ensure that we continue to engage and inform our industry stakeholders. This will include webinars like today, like this one. We are also known for our issue briefs and white papers and many of our other educational efforts that we have within the industry. We'll continue to work on that through 2021. We also, again, as I mentioned, looking at enabling consistent electronic exchange of additional clinical information, attachments. You'll hear it again throughout our session today. And I say attachments a little tongue-in-cheek because it's not necessarily a PDF or something that you fax over. It could also be just some clinical information or data related to a patient that's required to either remove the pend on the claim or remove the pend on the prior authorization that's needed, and not an actual physical piece of paper that needs to be transmitted over, right? So again, supporting emerging needs for robust eligibility and benefit information is also key. You'll see some work that we plan on doing in just a moment there as well. And again, one thing that we always do is ensure that any of our implementations, our core participants that are implementing the operating rules with their associated standards, we like to measure their success. We look at those implementation projects. If they've run pilots with specific users, perhaps it's a plan that's implemented prior authorization, for example, and they're working with one particular provider community. It's great for us. We can help measure the success of that implementation. They can certify and go through the voluntary course certification program. All of that's helpful for us as we continue to evolve, again, the ever-changing needs of the business. On the next slide, on slide 13, you'll see the specific initiatives that we have. number one there, the attachment subgroup. I keep bringing up prior authorization attachments. This one is an active subgroup today. We're continuing to work on developing very specific requirements related to attachments that support prior authorization. And maybe I'll pause real quick. I do want to highlight that although CAQH staff help manage the projects, they're really led by our industry co-chairs. We do recruit co-chairs from the industry. So I want to give a big thank you out to Mahesh, Bob, and Santo for helping lead this particular attachments work group related specifically to prior authorization. They've put in a lion's share of work, a lot of volunteer time to help us develop the agendas, review the documentation as we prepare it, and help us lead the discussions through the calls. We also have our core code combinations task group. This task group has been active, I think, for 7 or 8 years. Lena will know for sure, but it's been quite a while, and many of our co-chairs, Shannon, Nathan, Lynn, and Heather, have been with us the entire time. So they volunteered now for almost 8 years straight on working on this particular task group. So it's amazing work that they do, but it is a maintenance project, so it continues on and on and on. And they do great work related to the claims payments definitions and the coding that's used within the 835, within the remittance advice, to ensure that providers have the information they need to make sound adjustments to the claim. A couple other projects, number 3, 4, 5 there, we again are continuing our pilot and measurement initiative. We'll have a couple of opportunities here. You'll learn in a few minutes. We're continuing our work with prior authorization, but we'll also be talking about some work that we hope to do with value-based payments. We're also going to continue our attachments discussion with the claims use case. Those will be coming up in 2021. We have yet to co-chair those. So if anyone's interested in our core participants, please let us know. Obviously, Mahesh, Bob, and Santo have great experience from the prior authorization. We'll be looking for and rounding out that group with some claim use subject matter experts as well. Last but not least, the eligibility and benefit task group. We haven't launched a task group related to eligibility in a few years now, but we have had a lot of discussion, particularly with our participants, about some of the emerging industry needs, particularly related to supporting additional STC codes for explicit inquiries, tiered benefits, procedure level support, using a procedure code, a diagnosis code within the 270 transaction. Also, any type of remaining services or telemedicine, obviously with the COVID impact that it's had on telemedicine, there may be needs for eligibility as well. So lots of projects, lots of work to do, and we hope to engage the industry to make sure that we, again, build really sound sets of operating rules. Now, the next slide, and the last one for me, will be the really just a timeline, and this is our approach that we're taking for this year. For each of the different opportunity areas or initiatives that we have. Much of the first quarter will be involved in planning for our attachments for claims or E&B and our VBP, quality measured claims reporting pilot, with all of our rule development and our measurement taking place in the second and third quarter. We're trying to ensure and align with other industry efforts on each of these. So we want to make sure that we can match and maintain and continue to work with other industry groups like HL7, like X12, like WEDI, like the different organizations that are part of CORE, to help ensure that we have the right folks at the table, the right core participants at the table, so we ensure we get those different diverse perspectives that are really needed. But usually by the end of the fourth quarter, as we had last year, also for this coming year in 2021, we hope to have our voting processes developed and pushed out, as well as report on our different results. And again, our results may be different from different projects, right? Sometimes we publish issue briefs or white papers or educational webinars with different colleagues within industry. So be on the lookout for how we do that. We'll continue to make sure that you're up to date. With that, I'll hand the call back over to Daphne for our first polling question. Daphne?
Thanks so much, Bob. So now we'll take a brief pause in our presentation to hear from our audience. Are you interested in getting involved or learning more about the following CAQH core initiatives that Bob just covered? We want to hear from you, so I will give you all a few seconds to respond before we continue with the presentation. Wonderful. Thank you all. I'm going to close the poll now, and our staff will follow up with you over the next couple of days. And now for our next speaker, CAQH Core Manager, Lena Geber-Mariam. Lena?
Thanks, Daphne. So today we're going to be talking about the new CAQH Core operating rules on value-based payments. Next slide, please. So over the past 2 years, CAQH Core has conducted research to identify opportunity areas where operating rules could smooth the implementation of value-based payments. Throughout our research, we focused on 5 opportunities that range from data quality and uniformity, interoperability, patient risk stratification, patient attribution, and quality measurement. And across looking through at opportunity areas across all of these categories, Core kept in mind a vision for value-based payments, which is a common infrastructure that drives adoption of value-based payment models by reducing administrative burden, improving information exchange, and enhancing transparency across clinical and administrative verticals. So this first set of operating rules that were passed by CAQH Core participants and approved by the Core Board this past December focused on patient or provider attribution. Next slide, please. So often a provider does not receive the list of patients attributed to them for the purpose of value-based payments until well after they've seen the patient. It's often done retrospectively. It's often sent to a provider in these large, bulky Excel files that aren't integrated with the system. So these operating rules focus on 2 major points. One, how to bring that attribution information to the provider at the point of care. So when patient Smith shows up to their doctor's appointment, is patient Smith a part of their doctor's value-based payment population? And secondly, how do we better integrate those large Excel files downloadable from healthcare portals better into the physician's existing workflow and help them share large rosters of patients? So there are 2 sets of operating rules. The first, the single patient attributed status data content rule, builds on the existing mandated core eligibility and benefits data content infrastructure rule. This data content rule requires a health plan or its agent to return a patient's attribution status, that is, yes, this patient is attributed to you, no, they are not, as well as the effective dates of attribution every time they return an eligibility response. The second set of operating rules focuses on attributed patient rosters. So this data content rule standardizes the minimum data elements a health plan must return to identify patients within the value-based population. This includes the contract name, effective dates of attribution, all using the X12 834 transaction. We also have a set of infrastructure rules that standardizes the expectations for this exchange and requires health plans to send providers an updated roster at least once per month. Next slide, please. So going down into a little bit of deeper detail on each of these rules, our single patient data content rule, again, consists of 4 requirements which enable the return of patient attribution information in that X12271 response. The first requires conformance with the existing CAQH Core eligibility and benefits operating rule set. The second outlines how a health plan or its agent should identify the patient listed in the eligibility response. So in this response, a health plan must provide the explicit attribution status and effective dates of attribution for each of the core service type codes required by the existing eligibility rules. It also requires a health plan and its agent to develop and make available to the healthcare provider specific written instructions and guidance on how the health plan is implementing this operating rule, and provide the following definitions for attribution status. Next, the attribution-based requirements for receivers of the 271 response requires the product extracting this data from the response to make available to the end user the exact wording of the text included in the MSG segment. Next slide, please. Now moving up to the data content rule for our attributed patient rosters. Now, since this is a roster of all patients attributed to a provider under a certain contract, you don't need that attribution status. Instead, this data content requirement focuses on the identification of the actual health plan contract that these patients belong to, as well as identifying the attributed provider. Sometimes patients are attributed not at the individual physician level, but at the provider group level. So this rule requires that be made explicit in this roster. There's also a requirement here that requires conferment with the current published and adopted CAQH court connectivity rule, as well as requiring health plans and their agents to deliver this roster using the X318-834 transaction. Next slide, please. Since the attributed patient roster rule uses the X12, X318-834 transaction, and this transaction is not used by other core operating rules, it was required that we build an infrastructure operating rule that matches our existing infrastructure rules for other healthcare transactions. So similar to the existing CAQH core infrastructure rules that exist with HIPAA mandated transactions, this infrastructure rule has requirements around connectivity, the 86% system availability, the return of acknowledgements, the flow of a companion guide template, but it also includes a new requirement that requires that health plans or their agents send providers an updated patient roster for this value-based contract via this transaction each month. And these updated patient rosters should include the removal of patients no longer attributed, the addition of new ones, as well as updated effective dates of attribution wherever applicable. Next slide, please. And with that, I will pass it over to CAQH Core Manager Emily Tennick to walk through the new CAQH Core connectivity rules. Emily?
Thanks, Lena. So what I want to do now is provide an overview of the Core Connectivity Rule version 4 that, as Bob mentioned, was approved by core participants and the CAQH Core Board in December 2020 and published earlier this month. So just as Bob mentioned, there are 4 versions of connectivity as that technology has continued to evolve, but CORE's vision for connectivity has really remained consistent over these versions, and that is to address connectivity and security of administrative data exchange and establish a national base guiding healthcare communication. So with this vision in mind, the connectivity work group in 2020 aimed to achieve 4 main goals in the update to those connectivity requirements. And those goals were to really align connectivity requirements to help support some of the frameworks proposed in the CMS and ONC interoperability rules, including the use of REST and other API technologies. The second was looking at establishing and updating the core connectivity safe harbor requirements to make sure that we're supporting existing technologies such as SOAP and previous connectivity rules, but also looking forward to what's emerging using REST APIs to really ensure that a safe harbor is able to support both the standards that exist today and is flexible enough to support some of the more modern approaches. So next, as the work group thought ahead to future core initiatives, particularly with the newly published BBP rules that Lena just went through and the attachments rules that are in the pipeline we'll discuss in a few slides, wanted to ensure a single uniform connectivity rule was created that supports the intersection of both administrative and clinical data exchange. So this single rule includes all transactions that are addressed in core operating rules. And finally, again, just updating that national floor, guiding the connectivity communication in the industry. Next slide, please. So some of the key updates, we'll get into them a little further on the next slide, that they really aim to achieve those goals. And those include the use of TLS 1.2 or higher for increased security, establishing the use of both authentication and authorization standards, and specifically adding the use of OAuth 2.0 as an authorization standard, establishing requirements pertaining to those REST APIs I mentioned, which includes API endpoint naming conventions for both X12 and non-X12 payloads. And finally, adding support for the exchange of attachment transactions to really support the interoperability between administrative and clinical data exchange. Next slide, please. So again, the version 4 connectivity is that single connectivity rule that supports both administrative and clinical data exchange. And it both updates existing core connectivity requirements by adding support for the exchange of the attachment transaction, updating those security specifications that I mentioned, and adding that authorization standard. And it also establishes new REST requirements, so to support that emerging technology. And these key new REST requirements include support for both X12 and non-X12 exchanges, such as HL7 CCVA, PDF, text, etc., using REST, the use of JSON to exchange REST messages, support for specific HTTP methods, including POST and GET, to exchange messages, as well as error handling, status error codes to communicate those errors received, additional support for REST API and core connectivity versioning, and as mentioned, specifying API endpoint naming conventions. So similar to previous core connectivity rules, version 4 of core connectivity is a safe harbor for the exchange of SOAP and REST messages. And what that means really is that specific conformance requirements apply to stakeholders that choose to implement this rule. So health plans and clearinghouses or servers must support all connectivity methods, so both SOAP and REST. And then providers and vendors or clients must support at least one of these methods, so either SOAP or REST in this version 4. And this is really a key component of core connectivity because although trading partners may also choose to utilize other connectivity methods, if a trading partner insists on using the core safe harbor, that request can and must be accommodated. Next slide, please. So now we'll transition to the CAQH core operating rules that are currently in development, attachments and eligibility. Next slide, please. So we'll kick off with attachments. And as many of you know, the attachments process today is very manual, reflects a very significant burden for both health plans and providers. And there are many ways of conducting transactions that are related to attachments, and a variety of attachment standards that are available, many of which you can see listed here. Additionally, because a HIPAA mandated standard for attachments has not been named, there's really been a lack of uniform approach in supporting clinical documentation requests by health plans over the years. So in July of 2020, CORE officially launched its attachment subgroup for the prior authorization use case. Again, as Bob mentioned, while the initial focus is on the prior authorization use case for attachments and that work is ongoing, CORE participants will transition to tackle the claims use case beginning in mid Q2 of this year. And then a review work group will convene in late 2021 to review draft requirements from both the prior authorization and claims use cases to really ensure consistency and parity across those attachments rule sets for the two use cases. Next slide, please. So here we see a summary of the scope and key requirements that the subgroup that is currently underway has prioritized and voted to pursue. So to date, the subgroup has established requirements for two different draft rules, an infrastructure and a data content attachments rule. And I'd really like to highlight that both X12 and non-X12 exchange formats are included in the scope of these draft rules. And here we see that the draft infrastructure rule contains several key requirements, many that align with existing core operating rules for consistency. And you'll see a lot of similarities to the requirements that Lena just went over with the patient attributed roster rule, including the system availability requirements of no less than 86% per calendar week downtime, requirements for acknowledgement and the associated response times, the draft companion guide requirements specifying a common format and flow of the information, and then a newer requirement for attachments is the draft file size requirements, addressing the inconsistencies of system capabilities to accept various file sizes or megabytes of data, which can really cause errors at different system points. So the draft requirements should specify a minimum file size that must be accepted. Then the data content requirements currently center around data error handling and then several reassociation requirements. And those data error handling requirements really aim to establish standard methods and response times for receiving systems to return errors. And then the reassociation requirements were to establish consistent reference numbers or common elements between the prior authorization transaction and the attachment in a uniform way to address the reassociation of attachments that may not be able to be linked with the original prior authorization request. So this is what the work group has really been working on over the past few months, and we'll continue to work on through 2021. Again, this initial phase is focused on the prior authorization use case, and that will continue through the beginning of this year, and then will be followed immediately by claims use case. And with that, I'd like to hand the presentation to Taha Anjarwala, Core Senior Manager. Taha?
Thanks, Emily. So I'd like to now kind of walk through the rule development initiative around the eligibility and benefit verification process. So to begin with, the first operating rule set published by CORE nearly 15 years ago addressed this process, the eligibility and benefit verification process. And the goal of this rule set was to enhance the exchange of eligibility information exchange between health plans and providers by requiring the return of coverage-specific information for a set of service type codes and providing patient financial information such as copayment, co-insurance deductible amounts to providers so they had that information up front so they could collect patient financial responsibility at the time of service. And for context on adoption, according to the 2019 index, the eligibility and benefit verification is the highest volume transaction measured in the medical industry, second to claims, and continues to grow. And further, this transaction represents the highest annual spending and savings opportunity for the industry due to the large overall volume of this transaction and the volume conducted through partially electronic processes such as web portals. And looking forward, in fall of 2020, CORE asked its membership to identify priority areas for operating rule development that we could focus on for 2021. And our members identified improving the eligibility and benefit process as a top priority area for us to consider. And a key driver for revisiting and updating this existing operating rule is really around the emerging need for the communication of more robust information and the ability to specify a more granular level of data and detail, and looking at the industry shift and transition to more consumer-centric use cases. And some of the opportunity areas that were identified by our membership for us to potentially examine what operating rules could focus on include number one, which would be around the expansion of the number of service type codes that require explicit inquiries. And currently the current rule specifies, I believe 51 is required. So how do we expand that set? The second opportunity area is around addressing the industry need to communicate benefit information related to telemedicine, and especially with the impact of COVID-19 last year, there's the need for this is on the rise. Opportunity areas number 3 and 4 include providing eligibility information related to membership into your benefit plans and the potential for responding to procedure level request. And number 5 includes the communication of the number of visits or services left on a benefit. For example, the number of physical therapy sessions, you may have used 3 out of the 5 allotted on that benefit. The 6th opportunity area is looking at and supporting more dental specific requirements. And the last opportunity area, number 7, it looks on examining how we could leverage cost sharing information from the 270, 271 transaction for more patient or consumer centric applications. So CORE is currently in the identification needs phase of its integrated model. So we're just doing ongoing research at this point. The next steps include the launch of our environmental scan in February 2021. We'll survey the industry to send out a survey to the industry to gather insights across each of the opportunity areas I covered. And afterwards, in April of this year, we'll be launching a task group to begin prioritizing each of the opportunity areas, seeing what the industry level of support is for each one, and then proceeding to work on building out requirements to support and update to the eligibility and benefits data content rule. So, that's kind of a summary of our work effort plan in order to update the eligibility and benefit rule for this year. So with that, I'm going to hand the call over to Daphne for our next polling question.
Thanks so much, Taha, for the overview. Our final polling question today is related to telemedicine. So at the beginning of our presentation, Bob mentioned that we feel really strongly about aligning administrative and clinical activities and taking on projects that address industry needs. So we'd like to know from you what would be most helpful and important regarding telemedicine, whether it's education and e-learning tools, rule development efforts, and or any interest in collaborating. So with that, I will close the poll and hand the call back over to Taha. Taha?
Thanks, Daphne. So on the next slide, I'd like to kind of walk through our certification program. So the certification program has been around since 2007 and has provided a means for operating rule implementers to validate and demonstrate that their systems are in conformance through certification and testing. This program was developed by industry for industry through a transparent multi-stakeholder process, which is the same exact process that our operating rules go through as well. So essentially, the certification program is really designed to ensure that IT systems and products are really aligned to the federally recognized and industry developed operating rules and the underlying standards that they support. And currently, certification is available across all our published operating rule sets, with the exception of the new VBP rules and updated connectivity rules that you just heard of today, as the certification and testing platforms are currently in development, and we hope to have those available towards the end of this year, early next year. And another component I'd like to talk about is recertification. And this is really important, as recertification is there to ensure that we have ongoing conformance to the operating rules over time, especially as technology evolves, market conditions change, such as mergers and acquisitions are rapidly occurring in the industry. So this is really important, especially as operating rule compliance is being enforced by the federal government, and certification is being required more and more for health plan contracts. And just to give everyone a good picture, to date, we've awarded over 381 certifications, and these represent over 188 million insured lives, and we've certified nearly over 100 clearinghouses and vendor products. On the next slide, I'd like to kind of dive in and talk a little bit more about our recertification program, which was newly launched last year, and recertification is now being required starting in 2021. So, we believe that with evolving technology, mergers and acquisitions, system upgrades, there's really a need to assess ongoing conformance with operating rules to really maintain program integrity. Further, recertification enables organizations to align with healthcare operating rules as they get updated over time. And a prime example of this is that we're currently working to update our eligibility and benefit rule. So as that rule gets updated, that will be embedded as part of the recertification process. So in building out these recertification requirements, CORE held a multi-stakeholder focus group consisting of CORE certified organizations to really gather insights on what key policy decisions and requirements may be for recertification. And in looking at these requirements in detail, there are several key policies to keep in mind in terms of how recertification may impact your organization. So, and first of all, in terms of timeline, CORE certified entities will have to be recertified every 3 years. These renewals may occur at any time during the calendar year, and this is really based off the initial year of your initial certification. So after communicating an intent to recertify, testing for recertification must be completed within 180 days or 6 months. And if there's a lapse in renewing certification, CORE will proceed in engaging in an organization in the process of decertification. And the last item I'd like to kind of highlight from a policy perspective is that as CORE operating rules are updated over time, at a minimum, entities must implement versions of the operating rules that have been published 24 months or 2 years prior to the certification renewal date. Meaning, as an organization approaches their recertification date, they must consider and evaluate whether or not they will need to implement new or updated requirements in order to recertify. CORE staff will be there and available to help you to make this determination as you move forward with engaging with us in recertification. And lastly, I like to highlight that recertification is now required. So if your organization was issued an initial certification prior to 2014, you must recertify by the end of this year, by the end of 2021, to keep your certification active. So if you're a CORE certified organization and are not sure of what your certification status is or when you may need to recertify, feel free to contact us and we'd be happy to set up a call or kind of walk you through the recertification details and timelines. So on the next slide, I kind of want to highlight some of the measurement initiatives that we're working on through CORE certification. So as the industry implements operating rules and standards, the need to measure impact is really critical for to understand what the return on investment is and what the overall success for implementation may be. Currently, via CORE certification, CORE tracks the number of covered lives that benefit from the administrative efficiencies afforded by the operating rules and underlying standards. And these are published in an annual CORE certification progress report that we published on our webpage. And this report really captures the market reach and impact that CORE operating rules have on the healthcare system via the measurement of the number of covered lives. And later this year, CORE will be introducing a new measurement component as part of the certification program. And this is a way to really further enhance the value of certification. So CORE will plans to embed the collection of base efficiency metrics into the certification process to really support organizations in measuring impact of their operating rule implementations. And the goal of this effort is really to support priorities to track and articulate the impact of operating rules have on operational and workflow improvements. And as an optional benefit, CORE certified organizations will be provided opportunities to receive benchmark reports. And this would allow organizations to compare their own progress to other organizations and industry at large. And another benefit that would be an opportunity to engage in one-on-one case studies with CORE if you would like to further measure the impact that operating rules have on the efficiency metrics and possibly staff experience. So more updates to come on this topic, so stay tuned. And that's all the updates I have on the certification program. So I'll hand the call back over to you, Daphne. Thank you, everyone.
Thanks, Taha. And sorry, everyone, for the technical difficulties there. Just the stories of working from home, I guess. We do want to hear from you regarding our second polling question. So if in the end of webinar survey, you'd like to answer it or give us any sort of feedback regarding telemedicine, we of course want to hear from you. So with that, we can move right along into our Q&A. I'd like to remind you all to submit your questions by typing them into the questions panel on your dashboard. So let's jump into it. So let's start off with some submitted questions on industry trends and federal activities. The question on everyone's mind seems to be how a Biden administration might impact or accelerate industry interoperability efforts, and whether we see any changes on the regulatory or legislative front that might impact CAQH core specifically. So Bob, I will let you tackle this one.
Yeah, great question. And part of the answer is going to be a wait and see, right? I think that I know even late yesterday, there was some indication that any published rule or regulation in the last 30 days will be put on hold for the Biden administration to review. So that could impact the prior authorization regulation that came out this past Monday. So we know there's some direct impacts already to the work that we're doing as an industry related to prior authorization and those regulations. I think that again, part of it will be a wait and see. There definitely will be, I think, very significant changes in some of the approaches that a Democratic administration will take versus the Republican administration that just left. So we will continue to monitor much of this discussion. We do have our own federal and state liaisons that work directly with and review these types of issues. We'll bring those folks, and maybe even be a great topic in our next webinars, to bring those folks on and have them do a presentation. So maybe we'll take that back as one of our takeaways. But again, we'll have to wait and see some of the direct impacts. So it ought to be really interesting, and as you can imagine, lots of things to discuss as we move forward.
Definitely agree there, Bob. So next question is, what is the relationship between CORE's current and upcoming initiatives and FHIR?
I can jump in, and then if Emily or Taha want to also continue to add on to whatever I have to say. Obviously, we're always looking at where the industry is going when it comes to technology, particularly when it comes to the exchange of data, right? If we're going to have operating rules for the exchange of X12 formatted data for a claim or for an attachment or for a prior authorization, how we exchange that information is really important. So we've already drafted rules for the last decade for web services using SOAP and MON and REST. So obviously FHIR is in the mix, and it's something that many organizations have are potentially spending lots of money on and revamping some of their technology related to data exchange, particularly on the clinical side, and also with the member side. How do members have access to their information that a health plan may host? It's a little bit different on the administrative side when it's the interactions between a provider and a health plan. So a lot of that is still being defined and worked out and discussed. And we're members of HL7 and X12. We attend those meetings. They're also members of our own board. They're advisors to the CAQH core board. So we really are working really closely with these organizations that are kind of defining some of this technology that directly impacts the exchange of data. And we'll continue to do that.
Thanks, Bob. So looking at rules that pertain specifically to operating rules and rule development, we have a question here on how operating rules can benefit small healthcare practices.
That's a great question, right? Oftentimes we might get distracted by some of the larger provider hospital systems or larger networks, but how do we address some of the needs for small practitioners or single doc in the box type of scenarios? And one thing that I remember we did a great presentation just a couple years back with was a single provider, had one person that worked in their office that did all of the registration, scheduling, billing, and payment processing. And what really helped and what really struck me is that it's possible. It really is doable when the technology is there, with the roles and responsibilities related to the standard and their associated operating rules. If the data can move from the provider's office to the health plan, for example, a claim, the claim can be adjudicated in the payment, the CCD plus, the electronic check, and the remittance device can all flow back to the provider system and automatically post and automatically present the information that may have to be worked, right, those pins. And they can be more easily worked because the information that is shared to the provider is really, really clear, it's really distinct, it's very, it's automated for the provider to do that, and ways to resolve it is automated. That's really important, and that's really the role and crux that we have in the industry as someone that defines those types of operating roles. It should be just the ones that fall out or fall through the cracks that you have to resolve, those really hard pins, right? We're trying to get the information exchange from the provider to the health plan, from the health plan to the provider. So you only have to work the really tough ones, the really hard ones. And eventually, hopefully, even those go away, right? So that iterative approach, that step-by-step approach that we take in developing the operating rules leads to that, leads directly to that, right? We did our first pass for eligibility, and it was 10 STC codes. Our second pass extended it to 50 STC codes to be supported for an explicit inquiry. Guess what? This summer, we're going to be talking about the next set of STC codes and some of the biggest problems, perhaps potentially related to tiered benefits and telemedicine and other types of benefit structures that are really complex. If health plans can build a database for that complexity, then it should be able to respond back with that complexity within a standardized response. So the provider has all of that complexity and knowledge right at their fingertips, and they can make a really sound business decision in real time when the member is standing right there.
Thanks, Bob. So we have a great question here about our 2021 roadmap. Someone asks whether we are still pursuing a uniform infrastructure rule in 2021.
I'll take that one again. That's a great question. And although it didn't rise very high for 2021 as a key project, we're continuing to do our environmental scan. We have been getting some great feedback, particularly from provider organizations, because providers, again, are crux of this data exchange. They want to make sure that systems are available, up and ready for the data exchange to take place. They want to make sure that they're getting their acknowledgments so they know the health plan's received the claim or received the batch of eligibility transactions that their system sends every night at midnight. So those types of keyed infrastructure components within the operating rules, we're continuing to do that environmental scan to find out where the industry should lie when it comes to making modifications to the existing requirements. Today might be a response has to be returned within 2 business days. Perhaps that should be tightened down to within 24 business hours, 24 hours. Or if a real-time response is 20 seconds, perhaps it should be less. Most of the world now is really used to nanoseconds in returning data or for an on-screen interaction. So those are the types of things that we're doing now for analyzing the environment. And the feedback that we're getting from the different constituencies, providers, health plans, et cetera, is really helpful in that process. So although we don't have a date set for when that will launch, we are continuing to pull and cull from the industry their needs.
So we're coming up close to the hour here, but I do want to get one final question in. We have a couple questions regarding adoption rates that we've noticed across our operating rules. And more specifically, we have a question about whether we've noticed any trends regarding the use of the 60/20 or 60/10 on the PA attachment. So Bob or Taha, could you quickly speak to this?
I'll jump in, Taha, and feel free to add. I know you've been working on some of this as well. It's a great question, and I think what's going to be fascinating is our next version of our index, the 2021 index, the 2020 index that will be published shortly. We've seen some amazing trend lines, I think, when it comes to not only costs, but also related to some of the volumes that we've seen for prior authorization. There have been some increases. I don't want to steal all the thunder that's going to be coming out soon. But even from the last index to the one before that, we did see it's been variable. A lot of plans have implemented web portals and web services for providers to use, direct messaging, email, right, to facilitate a more automated process for prior authorization over the last couple of years rather than just fax. We know a lot of providers still rely on fax because they get a confirmation sheet. They know that the fax has been received by the health plan, and it's really hard to get away from an acknowledgement because they're so key to EPI, even if it's a manual fax process. So we understand that a lot of things have been in flux with PA, a lot of focus for the last couple of years. I think we're going to continue to see that, but we're also seeing a trend that automated standards like the 278, like many health plans have implemented a format for attachments like PDF, like a 275, like a CCDA, and we're seeing those trends appear within the data now. So it's great to see that the industry is adopting more efficient and more automated processes, even for PA. And we know it's always been a challenge for that particular interaction between provider and plan.
Thanks, Bob. And that's actually a perfect segue into our upcoming event. So early next month, the CAQH exploration team who puts together this, this index is presenting their findings. We also have a market-based review of the core comp combination. So ahead of that, we will be hosting a webinar on February 23rd. CAQH core staff will also be presenting at the Healthcare Payments Innovations Conference and the HIPAA Summit. So before I let you all go, I wanted to share some of the benefits of joining CAQH core as a participating organization. All of these rule development efforts and all of this great progress that you've heard about today comes from our participants, and our participants are really the ones who help drive these efforts and bring the industry forward. So if you would like to learn more about joining core, please email our staff. I want to thank you all for joining us. Once I end today's session, you'll see an end of webinar survey. I know that we went through a lot of topics today, had a couple of technical issues, and we want to hear your feedback and questions. So feel free to email us at core@caqh.org if you would like any more information on our operating rules or any other CAQH core activities. Have a great day, everyone.